So with that, I would love to introduce Dr. Juan Bowen from the Mayo Clinic, who is one of my idols, rock star clinician. He's going to talk about a general overview of these genetic conditions. Juan?
Well, thank you very much. I saw my very first patient with Marfan syndrome in 1980 when I was doing my training in Ohio. And it was a lady in the hospital with an infected cardiac valve. Eventually, I moved to Minnesota. And as many of you know, all of you probably know, there are many people of Norwegian origin in Minnesota. My son married a woman from the most Norwegian town in Minnesota, Spring Grove, Minnesota. So I feel a connection to Norway. Now, I'm a general internist. I'm not a geneticist. I'm not a cardiologist. So I have a general person's kind of perspective. Now, I want to say just a few words about the normal aorta. And you see the little round yellow elastic fibers or rings of elastic tissue. And they give the first part of the aorta unique mechanical properties with a certain pulse wave structure and velocity. But with age and with disease, those fibers become disrupted and fragmented, and the mechanical properties of the aorta are altered in an unhealthy way. Now, what can do that? Today, we're going to talk about the genetic mechanisms that can cause this, and we're going to talk about mutations in important structures inside the aorta, but also more recently, it has become apparent that signaling pathways, these can be called cytokines, or these are pathways that occur during the development in the embryo, but also persist during adult life. They can become disordered and can cause disease. And then we will not talk today about this list of the conditions, but this is important also. Sometimes just being quite elderly can give you a diseased aorta, or having extremely high levels of blood pressure inside the aorta can damage the aortic tissue and the elastic tissue. Very, very high levels of exertion can damage the aorta, although usually not too much, but it can damage the aorta. A very important family of disorders are the disorders that are called large cell vasculitis, and these are large vessel vasculitis. And we will not talk about these today, but this is what we have to think about when we see a patient with an enlarged aorta, because sometimes it's not genetic, sometimes it is an acquired inflammatory condition. And then there are certain toxins and certain drugs that can damage the aorta. Now, the TGF-beta signaling pathway is the most important pathway to consider. And the fibrillin protein is the protein that is mutated in Marfan syndrome, but it is a very important molecule which also serves as a regulator of this important signaling pathway. And there are components to the pathway, not only the fibrillin molecule, but the red is the TGF-beta molecule itself, and it interacts with two important receptors that you see in the green color. And then these produce signals that go into the cell, and other series of proteins eventually carry the message into the nucleus. So you can see that the signaling pathway has several components beginning outside the cell and ending up at the nucleus. And then important programs are turned on and turned off in the nucleus. And the result is a pro-inflammatory, pro-fibrotic type of process that can damage the aorta. Now, these are very important sort of historical highlights, and I could talk about this for an hour, but I promise I'll leave it at 1 minute. So Dr. Marfan was a French clinician. In France, he's known as the father of pediatrics, but he described a patient in 1896 with, later it was determined that patient probably didn't have Marfan syndrome, but his name became attached to the condition. But this is in many ways a surgical disease, so important progress really had to wait until the surgeons developed techniques for operating on the aorta. And then also a genius named Victor McCusick at Johns Hopkins University was the first clinician to really assemble all the parts and recognize important critical patterns. Eventually, a critical development in surgical management came from London, when the concept of incorporating a mechanical valve into an ascending aortic graft came about. And this led to a big jump in survival in Marfan syndrome. And then the more modern era is the sort of molecular era with the discovery of the fibrillin gene. I list Dr. Dietz here, but there are others, many others, who participated in the identification of the fibrillin gene as the causative gene in Marfan syndrome. He also is one of the key people in the TGA beta pathway discoveries, but also not the only one. And then also at the same time, in this genetic molecular era, Dr. Diana Millowitz, I'm choosing her as an example, but of course there are many others, of other proteins that have been identified with important mutations that also cause the disease. Also, she has been someone who has stimulated collaboration and cooperation. These are rare disorders, and it's difficult to understand the natural history unless you collaborate and combine the cases so people can see patterns. Dr. Reed Pieritz wrote this paper it's an editorial a few years ago. And really, when you do important basic research at the molecular, genetic, animal model level, and then clinical trials, you get results. And that is what happened in this family of conditions. So what I'm going to talk about a little bit now is how do we identify people? What happens to them? You can think of the natural history of a disease as if we did not exist with treatment, what would happen to the person? And then do we have good treatments, and what is the best treatment? So back when I first saw my first Marfan patient, the biology was less well understood, and today it's better understood. Now we have very good surgery compared to the past. We now have medical therapies that we did not have. We have animal models. We did not have those before. We now have human trials. And now we understand that it's not only Marfan syndrome. In 1980, when I saw my first patient, my concept was Marfan syndrome and nothing else. But now we understand it's a family of genetic aortopathies. Now we recognize people sometimes because they are referred because of their physical characteristics. Now this is a Minnesota family. This is another reason why we see patients. In this family, unfortunately, this young man died. It was not known that he had Marfan syndrome. And at the autopsy and with genetic testing, the disease was identified, and subsequently his mother was found to be severely affected and required surgery right away. This is another way that unfortunately we see patients. And more recently, there's so much imaging. You go to the emergency room, at least in Minnesota, and everybody gets a CAT scan, or you go to the doctor for a calcium scan, and oh, look at this, there's a dilated ascending aorta. So we receive patients through that pathway as well, many patients. Now, when we make a diagnosis, we have to consider all the diagnostic possibilities. And we start with taking a very detailed history. This is a personal history. And one of the things that appeals to me about this, because I'm not a specialist, many of the characteristics are non-cardiac and non-vascular. So we ask about the eyes, the musculoskeletal system. We ask about the family history. Then we do a very directed physical examination looking for certain characteristics. The physical examination that I learned it from Dr. Pieritz, the person who wrote the editorial, and I use his examination today. Imaging is so critical, and you could talk about this for a long time. Now, because we are in the molecular era, we depend on genetic testing for diagnosis many times. Once we have a good diagnosis, then we're able to plan. Now, these patients require lifelong care. So we have some idea with a very specific diagnosis about what is the prognosis, and then we have some very good ideas about how to manage their care for life. Now we're going to say just a few words about Marfan syndrome. In preparation for this meeting, I thought I better see how many publications there are. And these are how many Marfan syndrome publications I could find, and 295 in 2023. Now, this is the gene, and we won't talk about it, the molecule, but it's a complicated molecule because I told you it has several roles. participates in the formation of the elastic fibers, but also in regulation of critical cellular pathways. But we recognize people by the physical characteristics. The TGF-beta signaling causes all of these alterations in the body, and the lenses become dislocated in the eye, and I'll show you a slide about that. Breakdown of elastic fibers in the skin can be quite dramatic. And in the eye, we look for a certain type of movement, which is supposed to be running, but is not. But the eye has little fibers and connections that anchor the lens in place. And the molecule that is most active and most prominent structurally in the eye is in that part of the eye is fibrillin. So the eye has a characteristic movement, which didn't play on the video. They never do when you're actually giving the presentation. But we look for that on the physical examination. This is a patient of Vietnamese origin who came to my clinic, and he had very prominent stretch marks. And he asked his doctor, why do I have these? And the doctor said, I don't know. And he went Google and he said, could I have Marfan syndrome? And the doctor said, no, look at your face. You don't look like the Marfan syndrome. Well, this is a very intelligent man. He made his own appointment in our clinic. And of course, he had Marfan syndrome. These are the stretch marks that they're quite prominent on his skin. The normal spine looks like this, but unfortunately, with excessive TGF-beta signaling, you can have quite a dramatic alteration in the structure of the spine. Similarly, the canal that encloses the spinal cord and carries the cerebrospinal fluid can have quite broad and enlarged and cause clinical problems, as in this patient with Marfan syndrome. Now, I talked about the patterns on the physical examination, but in imaging, there are also patterns. This is a normal aorta on the left, and the aortic root, the first part of the aorta, commonly affected in Marfan syndrome. But sometimes not only the root, but the ascending aorta just above. So these patterns are quite particular to us, and there's a difference between root and ascending aorta. So this is, again, is a normal imaging study of the aorta, and this is a Marfan patient with a root enlargement. I'm going to move on to the Loeys-Dietz syndrome. And remember, we talked about the TGF-beta signaling having several components. It's like a chain with several links. And there are 5 or 6 now, Dr. Braverman knows for sure. Is it 6 Loeys-Dietz syndromes, I think, that are depending on which protein is affected. And again, this many publications, not as many as Marfan syndrome. And in the first half of 2024, we have almost 50. So in the second half of 24, we will probably exceed 2023. So this is a condition that is being studied more and more. And of course, this is Dr. Loeys and Dr. Dietz with an affected patient. And this is the characteristic finding that many, not all, but many Loeys-Dietz patients have a double uvula. Now, again, this is a normal aorta, and this is an aorta that has very prominent twisting and tortuous structure. And this has been recognized that is a very important marker for Loeys-Dietz syndrome, but also exists in other genetic aortic conditions. Dr. Braverman recently was one of the authors of a paper that was describing this in more detail as something that we should pay attention to. This is an aneurysm in the hepatic artery, the artery that goes to the liver. This is quite unusual and really should alert the clinician that this could be potentially Loeys-Dietz syndrome. And this is, again, an example of tortuosity in the artery that goes up to the brain. Now, these patients can have benign but numerous cysts in the abdomen, and the small arrow on the right points to another aneurysm that is in the artery that goes to the spleen. So these patients have tortuosity, they have unusual aneurysms. This would be an illustration of that pattern. Now, next to the final condition that I'm going to discuss is the vascular Ehlers-Danlos syndrome, a very difficult condition. And this is caused by a collagen mutation in the vascular form of collagen. And this has triple helix, complicated structure. And again, not as many publications as Marfan syndrome and Loeys-Dietz syndrome, but more publications every year. This is one of my patients who had this condition. It was recognized in childhood because she would bend over to pick up her cat, and the muscles would tear in her leg. And her mother took her to the Mayo Clinic, and this was the diagnosis. There's very prominent the visibility of the veins underneath the skin. The skin does not heal in a normal way with a very thin and unusual scars. Again, you can see these very visible veins in another patient. This is a large aneurysm in the subclavian artery. And this is a young lady who, frankly, our surgeons are afraid to operate on this aneurysm. And so it's currently being observed because of the extreme tissue fragility and because of her mutation. The aneurysms don't have to be very impressive. This is a composite on the left of this disease in Mayo Clinic patients and where we have found aneurysms. Finally, I will end with well, no, there's still one more. This is a really important thing to mention, that many patients have a completely normal physical appearance, and yet they have a family pattern of aneurysm. This is a man whose brother died at age 32 of an aortic dissection. And when you look at series of patients like this, you get a scatter of different mutations. In this particular series, fibrillin 1 patients and SMAD3 mutations were common, but in other series there are other ones. So it's a combination of mutations, but you only find a mutation 15 or 20% of the time. And that's probably because of today's technology. In the future, we will find more. And one important difference between this condition with the familial aneurysms in Marfan patients, Marfan in the red, the diagnosis tends to be made when the patient is young. But with the familial pattern, more and more the diagnosis tends to be made when the patient is a little bit older. Now, it's also been understood that larger aortas are often found in clusters, in familial clusters. So this is still a large area of research. It's not completely understood. Why do some people have this relatively mild course with nothing bad happens, and yet other people are like my patient with the brother, where terrible things happen in the family? So there is a lot of a research agenda here. Now I will end with this one. This is a common condition where the patient is born with a aortic valve. On the left is the normal aortic valve with 3 cusps. These patients are born with 2 cusps, but the programs that are responsible for the development of the aortic valve are complicated, and there isn't one single genetic mutation. Now, this is a paper from one of our clinicians at Mayo, that if you look at patients who have bicuspid aortic valves, they have a low risk of dissection, but they do have a risk of developing aneurysms that increases as they grow older. There really isn't a single genetic explanation. This is a complex condition that has to do with these developmental programs that occur when the aortic valve is being formed and the first part of the aorta is formed. Because it affects both, the aorta is weaker in people with these diseases. Here is a normal aorta with an MRI flow study, and you can see that the flow when the valve is open is very straight and laminar. On the other hand, this is a patient with a bicuspid aortic valve. The valve center is not in the middle, and the opening is not normal. So the valve opens in an unusual way, directs the blood flow to one side, where the high velocity jet has impact against the aortic wall. This is one of the reasons why these aneurysms tend to develop. In an already weak aorta, now you have this additional stress from the flow. Now, I said when I showed you the picture of Dr. Milowicz, that now she has encouraged international collaboration. This is now beginning to pay off with results. And you can see that in a study that was published 2 years ago, these are Loeys-Dietz genes. So not every single Loeys-Dietz mutation has the exact same natural history. And when you look at the black line, these are patients who have receptor mutations, and they tend to have consequences earlier in life. When you look at the blue line, these are the SMAD3 mutation patients, and they tend to have consequences a little bit later in life. So now with this international collaboration and larger numbers of patients under study, we do understand that is a different natural history for each mutation. So what have we learned in this past generation? Well, it pays to invest in research. It's very important to recognize physical features. This is very much a field where in the same room with the clinician, not by computer or video or anything, but you examine people, you touch them, you recognize patterns. But you also know that some people have unusual pattern or a physical appearance. They're not all the same. And some people even have a normal appearance. The vascular imaging is critical. There are certain patterns there. And the genetic testing is critical. We are in the era of molecular diagnosis. Now, are we finding all patients? The answer, of course, is no. We still have tragedies. And we wish that we were able to identify patients before this happens. And I don't have answers for this today, but these are some of the questions that motivate all of us and why we participate in this type of activity. So with that, I want to thank the Marfan Foundation. These are the Mayo brothers, the founders of the Mayo Clinic. And just like in Norway, we have this type of experience coming up soon. So this is my email, and I want to thank you very much.
Any questions? Sir.
Ivar Grønning, leader of the Norwegian Marfan Association. What do you think about artificial intelligence in relating to identifying?
Well, yes.
Repeat the question, will you, Juan?
Yes, the question is, what do I think of artificial intelligence in this field? So I myself don't have expertise in this, but I do understand. I think this is going to be critical. And particularly when you look at the last question is how do we identify people? I am sure that there are ways to look at data in large sets of data in ways that the human mind cannot do rapidly, but can do with computer aid. Already you're seeing much of this in all parts of life, and I'm sure this will be important.
Are there other questions? Bert?
Is it on? Okay. Dr. Bowen, I noticed that in the second to last chart, I believe it was, you were talking about when the incidents occur and you had the age of the patient, 20, 40, 60, 80. Can you elaborate a little bit on how we got to the fact that we even have a chart that indicates that people are having symptoms at 80, that they're living to that age?
Yes, this is a composite of reports. This is the Montalcino Aortic Consortium. That really the stimulus for this primarily came from Dr. Diana Milowicz from Houston, Texas. And by combining reports from many institutions in different parts of the world, these patterns emerge when you have hundreds of patients. So in our institution, we may have 15 patients with a SMAD3 mutation. But when you combine from around the world, you have 300 patients, then you can see the pattern of when they were reported. And by the way, when I talk about patients being reported, when you look at these publications, many of them really are family cohorts. So not only is there an index patient who triggers the attention, but then there's an investigation of the entire family, so that this is a wealth of information. But again, you don't see the pattern until you combine all these reports.
Awesome, Juan. Thank you very much.
Thank you.
Fantastic.